And so the attendees will start coming in as soon as,
Okay.
all right, we're started. And good morning, everyone. We're just getting started, so we're going to allow some time for all the attendees to come on in. Good morning. Good morning. And Renee, it looks like people are still sort of coming in, so I'll let you decide when you want to kick it off.
Okay. I just actually have a couple of instructions for everyone. So we'll go ahead and get started. And by the time Dr. Stefanski comes on, everyone should have been able to join our webinar by then. So just good morning and welcome everyone. This is our first session of our virtual learning series 2021-2022 session. All of these will be once a month, running from August until, and each month we tackle a different health topic that the community has requested additional information on. This series is hosted by the Region 4 Steering Committee for the region's Healthy Communities Coalitions and Alliances. If you're not aware of, each of our parishes throughout the Acadiana area has their own Healthy Communities Coalition or Alliance. If you'd like more information, you can just drop your email in the chat box and we can get you some information on those coalitions. A disclaimer, I think we always have to talk about our internet connections. If for some reason we do become disconnected during this webinar, no fear, just give us about 5 minutes. We do have a backup and everyone will be able to join back in. So I just wanted to make you aware of that. If you are having a bad connection on your end, we recommend that you log out and then log back in. And sometimes that'll help improve and boost your signal. Everyone will be on mute during the presentation. And so if you have questions, we'd like you to type them into the chat box, which is located at the bottom of your screen. If you click on that chat bubble, it will bring up a panel window and you'll be able to type your questions there. You will also be able to type your questions in the Q&A box that we'll be addressing during our Q&A session. And without further ado, I'd like to bring up today's featured speaker, Dr. Tina Stefanski. She's the Region 4 Office of Public Health Medical Director. So Dr. Stefanski, I'll go ahead and turn the floor over to you.
Hey, good morning, everyone. I appreciate the opportunity to talk with you all and hopefully answer some of your questions. And sorry for this slide, the screenshot of it's making me dizzy. I mean, there are a lot of moving pieces to our website. But before I got into a data update and into a little bit more discussion about vaccinations, I just wanted to just run through our website because there's a ton of great information. We continue to add information to this website, but it can be tricky to find. It can be tricky to find what you're looking for because again, there's so many things. And so if you go to the ldh.la.gov website, you'll see this. COVID of course is front and center there. But I usually go to the COVID-19 vaccine information. And then here you'll see, for example, there's a data dashboard. You can get all if you're looking for a vaccine location, just want to know more about vaccinations, kind of the latest on recommendations, guidance, especially as we move to these third doses or booster doses. All of this is here. Lots of great information, just general information regarding COVID and vaccine information. A lot of people are interested in our numbers. And we knew that would happen, right? Interested in our numbers. And so this is where you can go. I'm so sorry. I'll pause for that. This is where you can go to see, for example, what our latest information, rates of vaccination are in our region. And you can bring it a little bit closer. You can move the screen around. You can actually find out what vaccination rates are by parish. And actually, when you can keep scrolling in and you can actually get it by census tract, you can find very local information. So if you're interested in working in your parish or in your community, you can actually use this to help guide where where we might need to help do some outreach. Or we're using this, but if you also are interested in helping us, please, we'd love any assistance or suggestions. But you can see as a region, we're a little over 33% fully vaccinated. And again, you can keep scrolling in, you can get vaccine initiated demographics, you can get it by race, age. Again, all of this is very, really informative. You can actually break it down by parish if you want to see by parish, by age, completed and initiated. So again, I think that's something that a lot of people love using this website. But again, you really kind of need to know where you're looking, where you need to go to find some of this information. And I just wanted to point out, in the state of Louisiana, we've administered almost 4 million doses of vaccine. So it's wonderful. And we're just continuing to work to improve these numbers. So I just want to share that with y'all again before I got into the presentation. So now let's get into this. And this is my email address. If y'all got any questions following the presentation and y'all want to email and ask a question, please do. And if I can't answer it, I'll try to get it to someone who will. And just a reminder, Region 4 Office of Public Health is the Acadiana region. Work very closely, of course, with Renee, and I'm a proud member of the Women's Foundation Board. And we cover the 7 parishes of Acadiana, and we are under the Louisiana Department of Health. So we are essentially, you might think of it as the local or the state arm of the Centers for Disease Control. We're not federal government. We're not the federal government. We're a state governmental entity, but the CDC is not in each state. They rather rely on the state health departments. And so we're the state health department. We report everything up through the Centers for Disease Control. They're our reference lab when we need, and we'll talk about sequencing in a second. So we are tied very closely to CDC, but we are a state governmental entity. And so thanks for your support through your taxpayer dollars of the work that we do. So one of the things that we do is track reportable diseases. And so that, of course, over this last year and a half, COVID has really consumed so much of everyone's work. We still do have other diseases, unfortunately, in our community, and we really need to, when we talk about COVID, we all know that there are lots of challenges in our community that we need to work to address together. And Renee and Amy and these healthy community coalitions are working to do that. But COVID is really almost crippling the healthcare system. All of our resources, so much of our, not all, but so many of our resources are going, to address the COVID pandemic, and we really need to rally as a community to get past this so we can address things like our increasing STD rates, our mental health issues, chronic disease issues, etc. So back to COVID. One of the things again that we do track is data. So everything that we do is data driven, and this information is shared with our communities for visibility, and again, this information is updated on our website. So when we talk about the gating criteria, you might hear the governor mention this on his press conferences, or during his press conferences with Dr. Cantor, our state health officer. These are indicators that we've been following since the start of the pandemic. We have a tremendous Bureau of Health Informatics. So people who are doing testing, so these are urgent cares, labs, your doctor's offices, hospitals, your health units. We all report now through an electronic data reporting system. Of course, as you can imagine, the beginning was fax reporting. Now it's an electronic data reporting system. So all COVID tests are mandated, providers are mandated to report those. Those are gathered by Louisiana Department of Health and then compiled and shared with the public. So again, everyone can track and monitor the course of this pandemic. Similarly, hospitals report to us, and again, that data is then shared with leadership, and our communities. So these gating indicators, the 4 big ones that we've been monitoring throughout the pandemic, are emergency department visits for COVID-like illness, incidents, which is the number, the new cases. So these are new positive cases over a period of time. This slide reflects the number of tests that are collected, and then also our percent positivity, and then hospitalizations per capita over, again, over periods of time. So this is where we are as a state. The next slide is we'll talk more about where we are here in Acadiana. So again, we monitor these same gating criteria, and you'll see, unfortunately, with this 4th surge, we surpassed all prior surges in all of these indicators. So for here, we're talking about emergency department visits for COVID-like illness. And I'll tell you, interestingly, right around here, we were starting to see an increase with not just COVID-like illness, but also RSV. So y'all might be hearing that our young infants, we're seeing an increase in RSV cases, or actually RSV season is now in play. Usually RSV season, we talk about that in November, December, January. So our respiratory illnesses are, we're seeing an increase in RSV much earlier than we typically would. So some of this was RSV. Now it is this dramatic increase. It is absolutely COVID-like illness, but we still have some RSV. We still have some RSV scattered in with these increases for emergency department visits. We're hoping we might see a little bit of a decrease here. We're all working together as a community to increase access to testing. So if you start to see a decrease, hopefully some of that will be at some point with the mask mandates and increasing vaccination. We'll see fewer people seeking care. We're also hoping that this community access to testing will also move some of these individuals out of the ER. We'll continue to monitor that closely. Emergency departments are frankly overwhelmed, as you can hear. These new incidence of cases, again, much higher than any prior surge. First surge here in Acadiana, we weren't nearly as effective as they were, for example, in the New Orleans area. That second surge last summer was our peak. This is the post-holiday surge, and then this is where we are now in this fourth surge. Our percent positivity as a region is at about 18%. It was pretty stable the last two reporting periods, and we'll get an update tomorrow on our most recent percent positivity. So again, 18%. 10% is where CDC set that benchmark. We really want to be below that. And now, if y'all remember last year when we talked about starting school, we really wanted the percent positivity below 5%, because that, in order to reduce or limit, lower our risk of transmission on campuses. But percent positivity, what that means is the total number of people that are tested, how many or what percent of those tests are positive. So again, we're at about 18%. So almost 1 in 5 of tests that are collected are positive. And then this is the volume of tests. So you see that the testing has really dramatically increased. So the number of people seeking testing is huge. And that also gives you some, for the mathematicians out there, you can see that the more tests that are being done, you really would hope to see percent positivity drop. So this tells you that as our percent positivity remains high, we have a lot of COVID circulating in our communities. Is really the bottom line. And then the most concerning indicator is the number of hospitalizations in our region. Again, well surpassed any prior peak. We have over 400 people in hospitals just in Acadiana. I think our number yesterday was at about 411. That's huge. Our prior peak was last summer at about 304. So again, we were over 100, 100 more than we were at that time. And as of yesterday, we had about 50 of those individuals were on ventilators. That's really, really concerning. We know that once people are placed on a ventilator for COVID, it's really hard. It's really hard to get them off of ventilators. I mean, certainly some do come off, but it's a very concerning indicator of level of infection. I'm going to just talk a little bit about hospitalizations, because I think this is the only slide where I do. The concern and the pleas that you're hearing from the healthcare communities is real. Our hospitals are surging to care for those individuals who are admitted with COVID. This is affecting everyone. That surgeries are deferred, and the word elective or the term elective probably doesn't do it justice. These are people who might need heart valve replacements, bypass surgery, need surgery for cancer, to remove cancerous tumors. For example, these are surgeries where someone would probably need a hospital bed post-op to recover. So these surgeries have to be delayed because there's not the capacity in the hospital to add another hospital bed because of the surge that COVID has because of the COVID surge, frankly. And so if it's not a surgery that is if the person's life is not immediately at stake, then those surgeries, frankly, are being deferred. And so this is, as you can imagine, this this is going to build and continue to build. When you hear our hospital systems talking about some of these, you know, in the order of 100 plus a week being deferred, you can imagine that's just going to be compounded over the next several weeks. And so what are we going to do then when we get to the point we have several hundred people who then need catch-up for these surgeries? And so again, making the case that this is a problem for our community. We really need to rally together to reduce this number, to reduce this number. So sorry about that. Let's hope it's stable enough to get through this presentation. The new COVID cases by age group, and just to point out, it continues to be led by young adults 18 to 29. I'd say UL has done a tremendous job in trying to, in working to provide on-campus testing and vaccinations, and that's going on now. As has our other community colleges. We've been working with them to offer some vaccinations. But you can see the other age groups represented here. It's really increasing among all age groups, but in younger people most dramatically. And this is a group that has led the surge, the past surges, as you see very clearly, and also the group that's the where we see the poorest vaccination. So where that's why we're really trying to make some effort there for vaccination. Take these vaccination rates. This breaks it down by the age groups of under 30 years of age. Just to point out, as we're talking about the schools coming back, you know, together, K through 12, you can see that we are seeing an increase in that. That's this yellow line, 5 to 11 year, and the 12 to 17, which is buried behind this line. So again, we're seeing an increase in all age groups, even in those very young. We talk about 0 to 4, and of course, those infants, young infants, are those most severe. I also want to talk a little bit about nursing homes, because I think there's some success here that we want to talk about, something, you know, positive, right? And so I think that's this slide. You can see this is the number of new cases in residents, and while it is increasing, it's not increasing nearly as it did in past surges. So we've got, you know, over an 80% vaccination rate in residents in nursing homes. Not so great among staff, about 50%. But the residents are, you know, are very much more protected through vaccination. So that's, I think, a success story. And we continue to monitor this. So when we talk about new cases in the community, you know, over 98% of the new cases are in community settings, not in county. I just want to also show this, because this is something new as of last week. You know, our region is really highlighted, seeing a significant increase in COVID pneumonia, which is, again, a severe indicator. People who have COVID and then have pneumonia identified on top of that, or diagnosed with, you know, COVID is caused such lung issues that you've got pneumonia. We were essentially, again, highlighted as seeing a significant increase over the last week in COVID-associated pneumonia. So just, you know, again, more concerning. And of course, all of this fourth surge is driven by Delta, this new variant that in the United States is about 94% of circulating strains. Here in the southern United States, again, about 94, 95% circulating strains. And people ask, you know, how do you know what COVID you have, right? Do you have the original COVID? Do I have the UK or the Alpha variant, or do I have Delta? So right now the answer is Delta. Right. I mean, definitely just about all. You can essentially say all of the COVID circulating is Delta. And the way that we know this is through sequencing. So when I talked about CDC earlier, when you go to be tested, it's not like the flu where you can test and see if you've got strain A or B, right? COVID is still a novel or new infection. We still don't, you know, we're still working towards increasing capacity for testing, better testing. So now what happens is each state sends a portion or a percentage of their COVID positive samples through the CDC lab network. And so there's the CDC and contracted labs, and they do sequencing on that portion. So, so that is how it is essentially estimated, the percent of what variant is circulating in a community based off of these samples that are sent in sequence, because the sequencing can take up to a couple of weeks. So again, it's not a rapid test, but we use that to then identify or estimate what circulating strains that or variants, I should say, are circulating in the community. This is really important, and this continues to happen, you know, not just in the United States, but across the world, because these RNA viruses, every time they when they're transmitted, they replicate, and there's an opportunity for the errors in replication to occur, which is how you end up with these variants. Of course, most variants aren't as successful as Delta at evading some of the protections that some of the natural protections. And so the Delta variant is just one that is very good at being transmitted. And so it quickly overtook all other variants or circulating strains of COVID. And you've heard that it's on the order of at least probably twice as contagious as the original strains of COVID. And so while initially we'd say one person who had COVID might be able to infect 2 to 4 people, with the Delta strain, one person who's infected has the opportunity to infect probably 5 to 10 people. So again, really making the case for vaccination. So before we get to vaccinations, just talk a little bit about breakthrough, because of course that's of interest to everyone. So in these vaccinations, the 3 that we've got are still effective at preventing severe infection from this Delta variant. So when we monitor those people who are being diagnosed, and then those people who are hospitalized to determine whether or not they're fully vaccinated. So those not fully vaccinated are still accounting for about 90% of the new cases. So yes, we all know about breakthrough infections. We all know people who are fully vaccinated and still get COVID, but that is by far much more rare. What we're seeing is that 9 out of every 10 new cases being diagnosed, at least as of August 4th, and again, we'll get updated data tomorrow. Now, 9 out of every 10 new diagnoses are in people not fully vaccinated. Again, we talk about hospitalizations, a very similar picture. 91% of those people in the hospitals are not fully vaccinated. And then 83% of the deaths, again, people not fully vaccinated. And I'll tell you, when I speak with our the physicians, the staff that are in these hospitals in our region, this is absolutely what they are reporting. You might have heard last week, Our Lady of Lourdes, for example, their chief medical officer, Dr. Kaufman, at that time said that there was, out of all the ICU admissions that they've had in that hospital at Our Lady of Lourdes, only one was someone fully vaccinated, and that person was severely immunocompromised and was successfully released from the ICU. Everyone else in the ICU or that had been admitted in the ICU during this 4th surge were not fully vaccinated. You heard Lafayette General talk about their average age of admission during this 4th surge is 54 years of age, and their average age of death as a system, 54 years of age. I mean, I don't know what more, how more clearly, I guess, to make the case for vaccination and mask wearing and mitigation efforts at this very dangerous surge when we're talking about when we're looking at those local statistics. And then, so when we do talk about breakthrough cases, the median age is 74, and so older people typically have less of a strong immune response to vaccination. So you hear us talk about that with the flu all of the time. And so it's not surprising that it's an older age group where we see more breakthrough cases. But again, we do see them among all age groups. But again, when we look at the median age, it's 74. So I do want to talk just a little bit about vaccinations. And so again, I think some of the successes we talk about is this. We have seen a big increase in the number of vaccines initiated, but we did really when we saw this surge. I do think it drove people to vaccination because there was a lot of concern. It's slowed down a little bit, but we hope that we'll see a continued increase. I just wanted to show you all where we are as a region, and so this is first vaccinations administered by week, and so we're region 4, and so we had a great increase, and we too have seen a slowdown, as has really most of the state. So we just again want to enlist your help in helping us to increase these vaccination rates. But I think the good news is that they are increasing. And then this just is again just another way to depict the increased data over the last several weeks in vaccination. And this breaks it down by race, age, gender, and ethnicity. And I think one thing that it's interesting, this probably used to be, for anyone who was monitoring this this pie used to be great. You know, the 70% was more like this. So I think it's great that we're seeing really among all age groups an increase in vaccine initiation. Again, still not where we need it to be, but increasing. So that's wonderful. And again, we'll get more updated data tomorrow. But I think the last numbers that I heard of when we talked about children completely vaccinated, 5 to 17, for example, years of age, is at about 14%. So that's definitely our lowest when we talk about eligible for vaccination. But really, we see a great we see the greatest vaccination in people 70 and above, followed by those 60 and above, and then it really falls down, falls to much lower rates when we talk about younger adults. And again, when we're talking about the average age of hospitalization and death is much lower during this surge, we want younger people to realize the importance of being vaccinated. And then there's just a series initiated by Tony. Race, this is something that we all follow too very closely in addition to age. Y'all know at the beginning, there was a lot of concern that among the Black population, we might see a lower vaccination rate as a result of mistrust, understandably. I think in Louisiana, we've done a great job, and this just, you know, kind of points out where we are as a state compared to the US, you know, much higher rates among vaccination among our African-American population. And that's been a very, that's been wonderful. We've had great successes in working with pastors and leaders in the African-American community early on. And I think as a result, we're seeing these great successes here in Louisiana. And similarly in the Hispanic population, you know, we're seeing great vaccination rates there. As a state, you know, we've got ways to go, and we know that. Unfortunately, this is not unlike what we see, and Renee could attest to this, and Amy, when we look at indicators of health. Oftentimes, the southern U.S. Ranks more poorly than the rest of the country. We're less healthy, and so similarly with vaccinations, we're kind of following along, unfortunately, that same track. And so you can see this is percent of population with at least one dose, and then the percent of population that has completed the full series. And, of course, in this case, the darker, the better. The darker states have a higher vaccination rate than the states with the lighter dose. You know, one thing I know there's a lot of questions about, you know, is there some lack of transparency regarding adverse events following vaccinations, and lots of theories out there. And so this was actually updated the 18th, which was yesterday. And this is on the CDC website. There's a link here. And so there's many ways that CDC continues to track adverse events reported following vaccinations. And so one is through the vaccine adverse event reporting system, and there are a couple of others. So I want to just mention a few things. You know, we know that the vaccines were, at this time last year, we're still in that phase 3 clinical trials. We had tens of thousands of people. At first, so let's just talk about the mRNA vaccines, Pfizer and Moderna, because those were authorized for use first. So there were tens of thousands of people in both the Pfizer and Moderna clinical trials. Those individuals were, you know, those trials were wrapping up at about this time last year. Individuals were followed for a couple of months following, for 2 to 3 months following their last vaccination, monitoring for side effects, and then the vaccines were authorized again at the end of last year for use. Those same tens of thousands of individuals that were in those phase 3 clinical trials continue to be followed, and will continue to be followed for a couple of years. So we've got that data. We also have billions of people, you know, around the world that have been vaccinated to date. Of course, there's, you know, several different vaccine products around the world, but in the United States, we vaccinated, you know, over 300 million people with vaccination, with these vaccinations since they were authorized for use by the FDA. So there are millions of people just in the United States vaccinated. And so we've got tons of safety data as a result of that. Providers, patients, anyone can report an adverse event to the vaccine's adverse event reporting system. It's referred to as VAERS. And so anything can be reported to VAERS. There's no time period. There's no time period on that. If someone feels like there's some adverse event as a result of vaccination, it doesn't matter if the vaccine was administered a day, 2 days, 6 months ago. All of those reports are received and tallied, and then they're investigated. So as a result of all of that, CDC, collects all that data, investigates, and then reports. And so I thought it was helpful, especially considering this is very new data, just to review this real quick. So y'all know one is anaphylaxis. It's rare. That's when someone might have an immediate allergic reaction and have trouble breathing, for example, following vaccination. This was something that was that we knew about at the beginning as a result of the clinical trial data and early data. And so now we know the numbers are about 2 to 5 people per million vaccinated in the United States have anaphylaxis. It typically occurs within 15 minutes, up to 30. Now and it happens more often in people who have a history of anaphylaxis or significant allergic reaction to vaccination. And so that is why people who present and say, yes, when I have an injectable medication or I'm allergic to this medication, I develop hives or have trouble breathing, we watch them for 30 minutes. Interestingly, initially, there was such concern about anaphylaxis that if you had a severe allergic reaction to any injectable medication, it was a contraindication. That is no longer a contraindication. The only true contraindication to vaccination is if you had an anaphylactic or severe allergic reaction to a COVID vaccine. So if you say, hey, when I get penicillin, I have trouble breathing, you can still be vaccinated, but we monitor you for 30 minutes after vaccination. And if you do start to have that, if you do start to have symptoms of anaphylaxis, vaccinators are required. That's part of the guidance is to have those emergency medications on hand to address that. Y'all know about the Johnson & Johnson vaccine, this thrombosis with thrombocytopenia. So as August 11th, more than 13 million doses of the Johnson & Johnson vaccine had been administered in the US, and CDC and FDA confirmed 42 people who had this reaction. And so, and this is most common in women under the age of 50. So really the guidance now is we want people to know about this. They can still receive the Johnson & Johnson vaccine, but we always advise younger women that, hey, you do have 2 other options available, Pfizer or Moderna, and mRNA product. So we of course continue to track this. CDC and FDA are monitoring the reports of Guillain-Barré, which is a neurological syndrome. People, again, who've received the Johnson & Johnson vaccine, there is no link, there is no confirmed link. Again, just in the interest of transparency, that they're investigating or monitoring reports of Guillain-Barré. And so 161 preliminary reports in theirs. And again, these are still being investigated. And again, largely been reported, as mentioned earlier, most people have a reaction to vaccine early on, and so most of these have been reported in 2 weeks after vaccination in younger women. Myocarditis and pericarditis after vaccination is rare. Again, as of just a couple of days ago, they received 1,306 reports of myocarditis and or pericarditis. Myocarditis, pericarditis, that means an inflammation of the heart or the lining around your heart. In people younger, 30 and younger, mostly in men after mRNA vaccinations. So this is one to point out. So again, while the FDA, CDC received 1,306 such reports, they've confirmed 762 of those. So these were all not valid cases of myocarditis or pericarditis. And they're still investigating to assess whether or not there's a relationship to COVID vaccination. It is absolutely recommended that young men be vaccinated when we weigh with risks and benefits. So just to point that out, again, we tell parents, talk to your child's pediatrician, talk to your physician, and there are many more cases of myocarditis, for example, identified, diagnosed in individuals with COVID than as reported as a potential related to vaccination. And then when we talk about reports of death, this is one that I think has been perhaps touted on social media, and there might be some misconceptions. So I actually copied this from CDC, and again, this is the link. So again, anything can be reported to VAERS. And so reports of death, are rare. And so again, let's talk about the total number: 357 million doses of these vaccines have been administered in the U.S. Up until just a couple of days ago. So over this period of time, VAERS has received, a little over 6,700 reports of death among people who received a COVID vaccine. Again, there's no time limit on these reports. FDA investigates every one of these deaths. And then, so this is, as I just said, reports of adverse events to VAERS following vaccinations don't necessarily mean that the vaccine caused a health problem. It just means that a report was made because the provider or the person was concerned that there might be some link. And naturally, we want to investigate every one of those. So these have been investigated, and a review of available clinical information has not established a causal link to COVID vaccines with these reports. The caveat again is this causal or likely relationship between Johnson & Johnson and the syndrome that I mentioned earlier, the thrombotic syndrome, which has led to deaths. And so that's the caveat here. And again, I think that information is very well publicized and available for anyone to review. But all other reports of death were not validated. And so, for example, unfortunately, someone who might have had a heart attack, 2 months, a month after vaccination, and so that might have been reported to VAERS. That person would have had a heart. I'm not sure how else to say it, but the vaccine did not the heart attack in those cases. I'm just using a hypothetical, was not related to vaccination. The person would have had a heart attack anyways. So again, not sure how to say that very well, but again, just wanted to clear that up because there is some misconceptions here. And also, when you talk about vaccinations, and we know this because we've been successful at eliminating so many diseases, infectious communicable diseases through vaccination. So we've got a long history of this. Most side effects of a vaccine are going to occur immediately or within the first couple of hours or days. And so by far the most common adverse event, if you will, or side effect, it's not an adverse event because it's expected. The most common side effect of a vaccine is a local response, right? So your arm is very sore, you may get some swelling, definitely tenderness. If you have a strong immune response, you might actually get body aches, fever, headache. And we all hear, many of us, we all have heard or talked to people who've had those symptoms or experienced them ourselves, and that's your immune system's response. So that's actually expected. When we talk about one of these adverse events or concerning events, those two are more likely within the first, immediately the first couple of days. And so we talk about anaphylaxis, for example, but certainly by 2 months. That is through, historically through vaccination data, the most common, if there's going to be an adverse event, you should see that within 2 months. And that is why, and I think that clinical trials and before authorization, we actually waited, or the FDA, 3 months, 2 to 3 months after vaccination with those individuals in the clinical trials to be sure that there was not some unexpected adverse event in those clinical trial participants. So again, after 2 months, the risks of any type of adverse events, drops off, and that's through our years of vaccination data. So I just wanted to end with the new recommendations. So y'all know this, the third dose recommendations were just released a couple of days ago. I think last Friday, actually, the Advisory Committee on Immunization Practices voted and they essentially agreed with the FDA, who felt like a third dose should first be recommended in people who are severely immunocompromised because they're more at risk for prolonged illness, serious illness, and because they, as a result of their poor immune system, might not have mounted a great response to the vaccine in the first place. So CDC now recommends that people who are moderately to severely immunocompromised receive an additional or third dose of COVID-19 vaccine after their 2-dose series. So these are only for people who receive Moderna or Pfizer. There's still not enough data yet to determine whether or not there's individuals who receive Johnson & Johnson, whether or not they need this third or booster dose. So again, this is just for individuals who receive Pfizer or Moderna. And the recommendation is that if after, at least 28 days after your second dose is when you're eligible for the third. So if someone finished their series 2 months ago, they're absolutely, right within the timeline. If they just received it 2 weeks, they need to wait another 2 weeks before they're eligible for that third dose, or people, referring to the booster dose. But, want to make it clear, third dose, it's just another dose of the same vaccine. There's nothing special about this third dose. It's not any different. It's the same vaccine that you administered, that was administered to you on the first or second, which is why I think that it's the third dose is really the most clear. But people do refer to it as a booster, but again, it's the same formulation, essentially, a vaccine that you received before. And if you got Pfizer for those first 2 doses, you should get Pfizer as that third or booster. If you receive Moderna, you should again stick with Moderna. The vaccines are not interchangeable. And let's see, I think I get my little thank you slide is out of order. So who needs an additional dose? So what do you mean, what is meant by moderate or severe immunocompromising conditions? And I think ultimately a person needs to talk to their healthcare professional if there's any question. But this is the list. This is the list, FDA, CDC guidance to determine. So of course, people who have cancer are being treated for cancer, are immunocompromised, people, organ transplant patients, people who are taking medications, they're taking medications to suppress their immune system. Someone who's received stem cell transplant, so a solid organ transplant or a stem cell transplant, and they're still taking medications to suppress their immune system. People who are born with an immunocompromising condition, people who have advanced or untreated HIV infection, people who are on high-dose steroids or other immunosuppressing conditions. And again, or if your doctor, if you've got some other moderate or severe immunocompromising condition and your doctor agrees that it's important for you to get that third dose. And then when you do present for your third dose, this is what you'll be asked to do. You'll be asked to self-attest. So a person who meets one of these criteria does not need to come in with a doctor's note. It's self-attestation that you're being truthful, that you've got one of these conditions. And so you can either make a copy of this, it's on our website, or wherever you go for vaccination, they're supposed to also have these available either electronically or printed for you to again self-attest that you are eligible and you do meet criteria for a third dose of vaccination. And so I think today at 11 o'clock is my slides around. I think today at 11 o'clock is there's going to be more discussion about third doses for the population at large, and there's some suggestion that I guess the next month or so it might be open. This third dose might be opened up for a greater part of the population. But it sounds like we'll be hearing more about that in a couple hours. So that's all I have. I don't know if y'all, Renee, if you've got any questions, I can look.
Yeah, well, thank you, Dr. Stefanski. And that is the perfect ending that leads us into a couple of our first questions. So are there any underlying health conditions where someone shouldn't receive the vaccine? We do have in the chat someone that has underlying health conditions with active shingles, Epstein-Barr, NASH, vasculitis, and they've had other viruses. When should someone maybe caution to not take the vaccine?
So first, this is not, none of these vaccines are live virus vaccines. And so live virus vaccines is where you really get into people who are immunocompromised. And if there's some, depending on your level of your level of compromise, it's, with live vaccines, there's some caution. It's quite the opposite with COVID vaccine. There's no condition. In fact, many of those, people with autoimmune disease, people with other underlying health problems are more at risk for for severe infection. So it's actually recommended that people be vaccinated. I will say, we typically say with any vaccine, though, if you're if you're acutely sick at the time of vaccination, if you've got if you're running fever, if you're not feeling well, I do think you need to check with your doctor. So I would always advise that. But other than that, there is no condition, there is no health condition that where there's that should prohibit you from being vaccinated. Again, it's really kind of in this case the opposite is true. Those should really prompt you to be vaccinated. But again, I always tell people, especially if you've got lots of health problems, talk to your doctor before you vaccinated. For example, some people on certain types of medications, the doctors want them to get Johnson & Johnson because they might hold one medication so that they have a strong immune response. There's some people who are on certain medications that suppress their immune systems. And this is just, I don't think it's any recommended approach. It's just that physician might have some preference based on their information. And so I always tell people, talk to, if you've got a lot of health problems, talk to your doctor about vaccination. I suspect they're going to recommend it, but they may have some nuance in their practice that they've got some particular way that they'd like to do that, some series they'd like to follow.
Great. And then also you were saying that the shot contains no live virus. There's people that are saying, oh, I was perfectly fine before I went and got the shot. 3 days later, I tested, or 4 days later, I tested positive for COVID. Is this something that they probably had COVID before they got the shot and they just didn't have any symptoms? And should someone be tested for COVID before they actually get the vaccine?
Yes, that's a great question. We get this question a whole lot. And so with this vaccine, like any others, you don't get protection right away. It takes a while for your immune system to ramp up. And so actually with the COVID vaccine and with Delta, that second dose of vaccine is where you get the higher level of antibody that protects you against Delta. So with the original COVID strain, we actually got more protection after that first dose than we do now. About 2 weeks after that first dose, we actually had pretty good protection against the first strain. And then that second dose, it kind of sealed that protection. You had a high level of protection. With this Delta variant, you need a higher antibody level to prevent infection, and you get that after the second dose. So now if someone had COVID in the past, with that first dose, you probably get a little more of a boost than someone who never had COVID. But again, you need that second dose to reach that higher level of protection. So if you get one dose of the COVID vaccine and then 2 to 3 days later you develop symptoms, that is absolutely, and test positive. There's no way that can be linked to the vaccine. So it's not a live virus vaccine. It cannot give you COVID. The typical course is that you're vaccinated, and then within about 24 hours, your arm might be sore. You might run a low-grade fever, body aches, headache. Then that should resolve within about 24 hours. And so if someone has those symptoms right after vaccination, that's not unexpected. However, if on day 3 or 4, your temperature shoots up, you got body ache, just not feeling well, that's probably not vaccination, and you need to get tested for COVID. And I say that right now because there's so much COVID in our community. If you told me that in probably June, I'd say, yeah, get tested for COVID. But you might have something else going on. Right now, it's very high likelihood that you've got COVID because it could still be something else, but you need to rule COVID out based on the level of transmission in our community. So it's just that your body just didn't have enough time to build up those protective antibodies to really protect you. So you were probably exposed before vaccination, right after you were vaccinated, and then got COVID as a result of that exposure. It has nothing to do with the vaccine. So that's really important. You need to get 2 doses, but know that you're not off the hook. So even though you've been vaccinated, we all need to be wearing a mask. But even though you receive 1 dose of vaccine, you need to still consider yourself very susceptible to COVID. If exposed, wear a mask. Keep some distance between you and other people associated just with those kind of in your small circle. Because you are still at risk, even after 1 dose of vaccine. It takes about 2 weeks after that second dose, if you're going to get an mRNA vaccine, to get that full protection, or 2 weeks after Johnson & Johnson to get that.
Great. We have about 5 more questions.
Uh-huh.
2 are in the chat. One is about the screening process. Do all the states have a specific checklist of questions to screen people who would not be a candidate for the vaccines?
Yeah, so every state should be similarly following. So that FDA, although I do know, I think it's maybe like one county, perhaps in California, where they're giving booster doses. And I heard that on the national news. So that would have to be verified. But really most states, I suspect, are following the FDA authorization, CDC, Advisory Committee on Immunization Practices. You know, we follow their guidance. And so, you know, I don't, that's, you know, I think that's where you will see most, states and jurisdictions doing that. And so that list actually comes, the list that you saw in that self-attestation actually comes from that CDC and FDA authorization. I do think, I think you probably can, if again, if there's some county or some state that wants to go beyond that. I don't know how that works, but I imagine they might be able to do that. But I think right now you're seeing unity across the country where most people are sticking with that FDA CDC recommendation to use that list. And it's not really, so we say screening, but it's a self-attestation. So you don't have to prove, or you don't prove your condition. Again, you just hope that people are being truthful.
And Sheila has one more question. Would active cellulitis be advisable not to receive the vaccine? I'm sorry if I butchered that. I am not a medical provider.
Yeah, no, you did great. So again, that's something where I would talk to the person and I'm sorry, I would advise a person to talk with their doctor. If someone's battling an acute infection, they're going to probably tell you to wait. And the reason behind that is because you might not get a great immune response. You know, if your body is working really hard to battle cellulitis, you may not have as great a response to the vaccine. And so I would imagine most physicians would tell you, you know, let's get past your cellulitis and then be vaccinated. But again, you know, it just kind of depends. If that person is very much at risk for COVID infection based on where they live, what they, you know, their work, a physician might say, I'm more concerned about your exposure, and I'd rather you start this series now. So they would need to talk with their physician, because there's a lot of factors that come into play in making those kinds of recommendations.
Great. Another question is, this is heard quite often in the community, is why isn't the vaccines FDA approved?
And, you know, that's a hard one, and I don't really know the answer. I mean, you know, when I've asked or been in discussions with others who've said, like, you know, this is really, we've got millions of people just in this country that have been vaccinated. We've got tons of safety and efficacy data. Why is that? Why in this process faster? Is that it's a bureaucratic process? And I don't like having to say that, but that's the only response that I've heard to this question. And I think there's not a whole lot of clarity from my perspective, and on those that I've spoken to about why it's taking so long. And there's lots of people frustrated by that process, because they do feel like that there are people out there who are waiting for that in order to, you know, that's kind of their holdout, right? They're wanting to see this formal FDA approval. And I don't really have a good answer to why it's taken this long. I do know that there's hope that it's going to be in the next couple of months, but yeah, I don't know. I'm not exactly sure about why I can say.
Okay, that's great. I mean, that's an answer. And are there any predictions about long-term health effects or any effects of the body from the vaccine? We know it hasn't been out long enough, but are there any predictions or cautions?
So again, this is something that, you know, I've tried to read a lot about and talk to lots of people who I know would have these kinds of answers. And the overwhelming response is that, again, through our history of vaccinations, you know, over the decades and decades of evidence that we've got about vaccines, is that within the first 2 months is when we see, if there's going to be some type of adverse event, you see those in the first couple of months. And so I don't, so there is no prediction. There's no, any evidence to suggest that there may be some other long-term effect. I know that there are lots of people worried about the mRNA technology, and I think we should be proud. UL has a research center, the New Iberia Research Center, and they do tremendous work, and have for years. They actually were very involved in the clinical trials with Pfizer, and so and speaking with the director of that center, about the mRNA technology. It's not new technology, so it's not something that was so it's not new technology. It's this technology that they've been working with for a few decades, and it's kind of the wave of the future, right? Which we're in with vaccinations. This is where science and medicine was headed, and so as a result of that technology and the successes with their prior work with mRNA, they were able to I think a tremendous testimony, right, to science that Operation Warp Speed was able to within that year or so able to develop and produce these vaccines that are safe and effective. But again, I think that's something a lot of people understandably kind of question, because we did not, mRNA is a new word for most people, mRNA technology. And so that gives some people pause. And so I do think it's helpful to know that this is technology that was already, has already been in play, used in, there are certain therapeutics where mRNA technology is already utilized in cancer treatment, for example. It's in vaccinations that had already been researched for Zika vaccines, for example. So not new technology, just new to this scale. And thankfully it existed. I'll tell you, without these vaccines, can y'all imagine? I can't, where we would be now as a world with this very contagious form of COVID.
And last question, Tina, what would you say to someone, because we're hearing this a lot as well. Well, if I can still catch COVID and still pass COVID, then why should I be vaccinated? What can we give as a response to that statement?
Sure. So if you get vaccinated, it is highly effective at keeping you out of the hospital. It is highly effective at preserving life and preventing severe disease. And so I think that is overwhelmingly the most important reason to get vaccinated. So someone who's vaccinated does have a risk of breakthrough infection. It's a smaller risk, but absolutely a risk. But we know those people overwhelmingly recover at home. And so, so I think that to me is that if you get COVID, like we talk about with the flu, again, this is not new in the world of vaccine. Even if you do have a breakthrough infection, just like we talk about with the flu, it won't be as bad. And with COVID, you should be able to recover at home. And so I think that is overwhelmingly the most important reason to get vaccinated. And I also want to say, there's this monoclonal antibody treatment, which is wonderful. But what we're hearing is that people are using that as a crutch and saying, I'm not going to get vaccinated because there's a treatment available. That is the wrong approach. Number one, we need to focus on prevention. And that's what vaccination gives to us, and masking and these other mitigation efforts, but certainly vaccination. When we're talking about a treatment, we're talking about an infusion that's also under EUA authorization. It's not FDA approved for treatment of COVID. It is very costly monetarily, but also the human toll it's taking on the healthcare system to operate these infusion centers, to get people in who really need it in a timely fashion is our healthcare system is struggling to do that. And so I think it's, I want people to really understand that we need to prevent infection. We need to preserve our health, our long-term health, the health of our healthcare system. And that's through prevention and not relying on these other measures. So I think that is really the strongest case for vaccination, is that even if you do get a breakthrough infection, you should be able to recover at home and not end up in the hospital or in the ICU or worse.
Well, thank you so much, Dr. Stefanski. This has definitely been an informational session for us. As I give our closing remarks, if you could possibly put in the chat, someone requested the website to report for the adverse health events. So if you could put that in the chat, that would be great. But thank you so much for your time here today. I know you are pulled in a lot of different directions and your schedule is very demanding, so we appreciate you joining us here this morning. I also wanted to let participants know that the session is being recorded and a link to the recording will be emailed out to everyone after this session. We also have another session this afternoon from 6:15 to 7:15 with a panelist of physicians who are talking about the vaccines as well. That will be sent to you. I'd like to thank our committee members for the steering committee. They are represented by the Office of Public Health, the Louisiana Campaign for Tobacco-Free Living, Women's Foundation, Louisiana Action Coalition, and Louisiana Nurses Association for Region 4, Blue Cross and Blue Shield of Louisiana, United Way of Acadiana, and Opelousas General Health Systems Foundation, the Healthy St. Landry. I'd like to thank everyone and these committee members for the hard work in getting this information out to everyone. And I hope everyone has a great day. And please join us next month as our monthly health topic will be mental health and suicide prevention. September is Suicide Prevention Month. So you can just register at the same link and join us next month. I hope everyone has a great day and thank you for participating.